2020. Boy, do we have a great show for you today. I am so fortunate to have two doctors on the show. So we are going to be talking about underlying medical conditions and fighting the COVID-19 virus. I think that I want to kind of preface some things first about what this show is going to be about. Yes, underlying conditions, but what I've been hearing a lot in the news and have known for a long time, in particular the African American communities and perhaps some other minority communities. And I want to quote that word minorities because I don't really like it, but I'll just use it today just so people understand kind of what I'm talking about. That we sometimes do not eat correctly, we don't exercise, we don't do some of the things that we need to do early on in our lives, and there are things that this may stem from, right? And maybe we'll talk a little bit about that as well. So we want to kind of give an idea of what we can do to make these changes and to live a better life, and maybe build up our immune system so that when viruses like this come along, perhaps we will not be so affected by them. Well, also for the athletes, fighters out there, you cannot be a good fighter if you are not eating properly and taking care of yourself. So things like that we certainly want to talk about. And why does it affect certain communities, or has affected certain communities worse than other communities? I think those are a serious discussion. It's a serious discussion about what we need to do, what our responsibility is in all of this as well. So some people might get a little, he's talking about race and he's talking about culture and all this. My saying is that we are not defined by race, but we're defined by cultures. But in this thing, there are some things that might affect a certain race differently than it does other races. Might be, but we know there's a social economic factor in all this too. So we just want to, again, entertain all those things. Always, we want to thank our sponsors, Blackout Fights at blackoutfights.com. You can check them out on my website at promotions.org, as well as their website. If you want some good fight gear, always appreciative for what they do for us. And also Eastern Offset Printing. They're out of Atlantic Beach, North Carolina. So before I get the show started with and bring on my guest, there was an article that came out not so long ago by Dr. Lisa Cooper, and she has some interesting statements. So I want to preface this interview with that article, and then I'm going to ask the doctors what they think about it, and we'll bring them up in just a second. But Dr. Lisa Cooper, an internal medicine physician and a professor at the Johns Hopkins Bloomberg School of Public Health, she said, and had to speculate, given the dearth, hold on, my thing is writing there, the dearth of the data, but she listed multiple reasons why, as a group, African Americans of lower income are more likely to become ill. People working for an hourly wage don't have the luxury of being able to shelter at home or the means to buy 2 weeks worth of healthy food. She also said they may work in jobs deemed essential and such as public transportation, public safety, or healthcare. If they quit, they will lose their health insurance if they have it at all. If they continue working, they risk exposure to the coronavirus. And they are more likely to have diabetes, high blood pressure, asthma, chronic conditions, etc. African Americans in many large cities began to practice social distancing behavior much later than whites, largely due to the fact whites could stay at home and work from home. Brian Williams, another trauma surgeon of intensive care, he said that he was so surprised that 70% of the people who died from the virus were African American in Chicago. That is an amazing number. We want to know a little bit why that is. So without any further ado, guys, what I'm going to do is bring up two people who really, really know what they're talking about. First, we're going to bring up Dr. Lucas, who is a pediatric cardiologist. someone who we've had on the show many times. He's also a fight doctor and a very, very knowledgeable, I say young man. That's because I'm old, right? And next we're going to bring up Dr. Lutz. She is a doctor in the Charlotte, North Carolina area. And to be honest, she was one of the people that on Facebook that I noticed she sounded the alarm. I mean, it was like, hey guys, you need to take this pretty darn serious. And that was kind of early on. We want to talk to her a little bit about that as well. And how are you guys doing today?
Doing good, Johnny. How about you?
Doing just fine, Dr. Lucas. And how are you doing, Dr. Lutz?
I'm doing great. Thank you.
Good. I want to thank you guys for being on the show today. Again, our goal is to try to educate people on, some of these causes and why this might be. We're going to try to definitely keep this under the hour because you guys already know that I'm a little long-winded and everything. So I certainly will, try to keep my verbiage as short as possible. But I do want to ask, Dr. Lucas, have you seen any COVID patients at this time? Or do you know what's going on in your hospital?
So, I mean, I personally have not seen any COVID patients, but I mean, I'm a pediatric subspecialist, so I shouldn't be seeing COVID patients. Mm-hmm. We have had a couple of our patients get admitted to the hospital as PUIs, persons under investigation, because they had a fever. One of them had a known exposure to a person with COVID, but as of yet, they've all tested negative. So I haven't actually seen any of my own patients with coronavirus. Our hospital system, which is the biggest hospital system now in South Carolina, has a number of COVID patients, and they've made some pretty significant changes to the way patients are seen. They actually emptied out one of the outlying hospitals and turned it into a facility strictly for COVID patients, so they can try to isolate them all in one place and reduce the risk of cross-contamination from staff and providers and other patients and things like that. But, as you probably know from looking in the news, just like what it sounds like you're seeing in North Carolina, currently South Carolina's medical system is doing very, very well as far as managing the level of COVID patients. We have lots of capacity left, and they haven't even done some of the additional measures they had talked about to increase capacity, like hospitals and tents, field hospitals, things like that. So we're doing good now, and hopefully it continues that way. The social distancing is definitely paying off.
Nice. Dr. Lutz, how's it looking over there and what you were seeing in North Carolina?
Yeah, I think our numbers are pretty comparable to South Carolina as well. And like Dr. Lucas said, we still have plenty of capacity. I think we haven't yet hit our surge. I think our surge is predicted mid-May now. It continues to be pushed back, which is good because people are doing what they're supposed to be doing with social distancing. So we're, flattening the curve. I do have patients that have COVID. One of my patients recently was discharged. She's a pregnant patient. She was midway through her pregnancy, but she has done well. She was managed on oxygen, didn't require intubation or anything or ICU admission. My patient mix is pretty diverse. I have, I'm fluent in Spanish, so I have maybe 20% Hispanic population, maybe 30 to 40% Black, and then the rest are Caucasian or white. Right. All of the patients that I have had, I have maybe 6 or 7 patients that have been positive for COVID, have all been Black, which is interesting. So that's, I mean, that's just.
Let me ask, Dr. Lutz, why do you think that is?
I can only speculate. So I'm not sure. I can only speculate. I mean, 10% of people that are being tested within our system, which is Atrium Health, which is the largest in North Carolina, 10% of the people that are being tested are testing positive for it. And I think that's similar across the nation, probably. I can only speculate that when I initially started to see patients and so-called sound the alarm, that Black people had the impression that Black people were immune, that it wasn't gonna get to them. Okay. And I don't know if that's initially because a lot of the countries in Africa, it didn't hit them initially, or they weren't seeing data, right? Or because there was a lot of social media articles going around that it was a conspiracy, or that they didn't believe that it was real. And so for a lot of African-American communities, social media is the news, right? So so whatever is going on in social media, I think it was a perception. And so I do think there was a delay in social distancing in the African American community, and I don't know that they technically believed it. I can only speculate on that, though,
Right. Well,
as to what the reasoning
that's
is.
very interesting, Dr. Lutz. Dr. Lucas, what have you seen when it comes to any kind of disparities in your numbers and where you are?
So it's, our testing percentages is almost identical to what Dr. Lutz is seeing. And, I'm in upstate South Carolina, so I'm only about, probably 45 to 60 miles away from where Dr. Lutz is. So not surprisingly, the numbers are pretty much the same, but we're seeing about 10% of the tests that are being done are turning positive. And as has been the case across the country, the African American community in particular is definitely overrepresented in the positive cases. I think in South Carolina they account for somewhere around 50%. I can't remember. I heard that statistic last night, and I can't remember now if that was the national statistic or the South Carolina statistic. But I know that in both places it's pretty similar. They're wildly overrepresented compared to their percentage of positive.
In your opinion, Dr. Lucas, why do you think that is?
I don't know. There's lots of reasons for that. Like, we're going to end up talking about pre-existing conditions at some point. And just like African Americans here in the South are overrepresented in the hypertension statistics, they have more strokes, they have more kidney disease. I think that there's a number of reasons for that. And a lot of them are things that have been long standing. The African American communities here, at least in the upstate, some of the African American communities are overrepresented in poor, and being poor in the United States is definitely not a good plan as far as having excellent health care. There's definitely significant disparities and outcomes in every disease that track exactly along with income. The more money you make, the higher affluence the area you live, the more likely you are to do well. And that if you go to the good area of town, there's going to be for sure a hospital there. There's going to be tons of doctor offices. There's going to be lots of grocery stores. It's going to be easy to get fresh produce. It's going to be safe to go outside at night and exercise. If you go to some of the poorer areas, poorer urban areas, almost none of that stuff is true. There's not likely to be a large hospital. There may be some clinics. A lot of times there are clinics that are either volunteer or they're staffed by physicians who sort of rotate through. So you're less likely to have a state primary care physician. It's harder to get healthy food. Might not be safe to go out and run. I can go out my house and run. I'm not worried about getting shot. And if I do get shot, it's going to be by accident by someone who was shooting at a deer and, didn't have a good down get shot.
For the most part, yes.
Yeah, for the most part, it's not a regular occurrence.
Yeah, but I do want to. You mentioned something earlier about there'll be more clinics and stuff like that. So when it comes to testing, right? Has that been a little slower to get to these communities? Dr. Lutz, won't you take that one on? Have you noticed that it's been a little bit slower?
Well, particularly in our system, I don't think that's the case. And I don't think that attributes to the difference. Because in fact, if there's more African Americans testing positive, then that indicates that they're getting tested, number one, right? So there's a difference between why there's more getting tested positive and why more are dying from it, right? So I think that why there's more dying is because of the underlying medical conditions, but why more are testing positive. There's a difference between that. But within our systems, though, we have a mobile testing unit now that we have gotten to go out into the underserved communities, because if you don't have transportation, you can't go get tested, right? So if you can't afford to go to the clinic, you can't get tested.
Right.
I don't know what the data is, though, across the country. And I would imagine, as Dr. Lucas said, that in these areas, these rural, particularly rural, poorer areas, that if there aren't testing centers, these big testing centers, like we work in academic centers, that you don't have that access. We have drive-up testing centers where you can go drive up to get tested, but what if you don't have a car? How are you going to drive up to get testing if you don't have a car, right? So I think that in those rural communities, it's going to be very difficult for them to get testing. And so if they don't have a regular primary care doctor, I can't even imagine how they would even know to get tested, or if there's how far the nearest health department is. So I think in those communities, they're particularly vulnerable. We bring up the Black communities, but there's also the Native American communities also that are impacted by this too, as well as immigrants who are being affected by ICE. And so there's political factors as well. So they don't want to go to the doctor because they don't want to get caught, right? So if there's this, enforcement of wanting to stay at home, or having to stay at home, they're going to stay at home even if they're sick. So I've been seeing that a lot too. Patients are sick. They don't want to go to the emergency room, one, because if they're an immigrant, they don't want to get caught being out on the road. And number two, people are fearful of being evaluated because they think they're going to catch coronavirus at their doctor's office or at the emergency department. So people are also dying because they're staying at home, they're having a heart attack, and they're staying at home because they don't want to go to the emergency department. So I think some of the deaths that we're seeing are not just from COVID, but because of things that could be treated, but people are staying home and they don't have the health literacy to know that they should still be going in to see their doctor with life-threatening conditions.
Right. Well, they were talking about,
problem.
when you talk about the underlying conditions and things like that, one of the things that we're going to cover, like some of those specific bullet points, but one of those were like people over the age of 65. And Dr. Lucas, if you could tell me, is there something that happens to your body when you become 65 that would make you, or is it the way you've lived? I mean, give me some insight here.
So you're going to ask the pediatric cardiologist to comment?
Right. That's unfair.
Right. Okay. Both of you can take that one on.
No, but I mean, yeah. So just like when you see any statistic, in order for statistics to work, you have to pick a cutoff. So it's not like if you're 64, you're at no risk, and if you're 65, you're going to die if you get coronavirus. But that's a common cutoff, especially in the United States, because that's when Social Security and all that kind of stuff. So that's sort of what I think the general public thinks of as being elderly, is sort of 65 and older. As you know, for any condition, if you're older, the older you are, the more likely you are to have things that are going to be either comorbidities or you're going to have a heart problem with that particular type of issue. So like going back to heart disease for a second, we send little kids down, babies, to have open heart surgery, and the parents always ask me, what's this scar going to look like after they have their surgery? And if I'm 45, if I go and have open heart surgery at 45, or if my dad, who's 70, goes and has open heart surgery, you're going to wind up with a scar that looks one way. If somebody who's 3 months old has open heart surgery, their scar is going to look significantly different because they're a baby and they have baby skin and they're designed to heal. I mean, you remember being a teenager, you could practically break your leg and like watch it heal and fracture.
Right.
I wake up some mornings and something hurts and I can't figure out what on earth could possibly have happened. So it's just that our bodies don't heal, our immune systems don't work as well, they don't heal as well when we're older. So it's not surprising that people who are older are more prone to having complications from this.
Okay, so let me know very good, Dr. Lucas, Dr. Lutz. Is there a difference between, and I know this is a really general statement, between an African American or a minority person that might be 65 and maybe white? I know that probably where they live, and there's probably a lot to that, but I'll let you answer the question.
Yeah. So, and I was thinking of that when you asked him that question. And the problem is that even at birth, Black people already have a decreased life expectancy. And so,
hold on, why is that?
Okay, so that's a loaded question.
It's a very loaded question.
So the American Academy of Family Physicians has been working on this health disparity issues for a couple of decades now. It is, the big thing on our list. And so there are what you would consider upstream factors and downstream factors. And so upstream factors being societal issues, right? And so political issues, poverty, socioeconomic factors, mass incarceration, those types of things. And then there's downstream issues, which are individual factors. And so our behavioral issues, our sexual behaviors and habits, whether or not we exercise, how we eat, those types of things. And so both of those things affect those things. I mean, almost from birth. Okay. So being born into, a society where there's mass incarceration, where there's more likely to be single parent homes and lack of, a support system or a family. I mean, let's be honest and speak frankly here, most Black communities and most Black families are growing up in single parent homes. And so that is going to affect your health, from the beginning. And even as Dr. Lucas said, if you're growing up in an environment where you are more likely to be shot, on the street, just going to the store to buy something, your life expectancy is decreased. And so it's not just, health issues, but it's also violence. However, I will say in the past 15 years, the data shows that the death rate has declined by 25%. So we are making gains in that. But the biggest thing, and then what this has to do with COVID, is that a couple of the major risk factors in death, specifically hypertension and diabetes, are things that typically we see in older age, right? But in Black people, they're getting it at much younger ages. Okay, so they're getting it in their 20s and 30s instead of maybe 50s and 60s, you know, in the white counterparts. Part of that, as you said, is dietary exercise habits, and part of it is that, at least for me, I don't see people coming in to see their primary care doctors, right?
Right.
So hypertension is a silent disease. If people think that, oh, I feel fine, I don't need to see a doctor, they're not going to see a doctor, right?
Right.
In addition to that, you know, like especially Black men in particular, they don't want to see a doctor. So if the Black men that I see, they come in because their wives brought them, or their girlfriends brought them, or their mother told them to come, you know, right?
Right.
So there's also a mistrust of the system, right, among Black communities, which is not unfounded. You know, the Tuskegee trials in the 20s with
Yeah.
you know, practicing on them with syphilis and doing those types of things.
Yeah.
Can you really blame them? So trust has to be earned, and so we have to get trust with the African American community, saying that we do want to help them. And so part of what needs to be done, as an upstream factor, is getting more minority caregivers to provide for the patients, and so that they can trust them. Not to say that they can't trust, you know, a white doctor to care for them, but sometimes it's easier for them to trust somebody that looks like them. And that goes with Hispanics, you know, people that can speak their language, those types of things. And so there has to be a cultural competency that is involved in taking care of patients so that they can trust them. But hypertension and diabetes hits Black people earlier than it does white counterparts, period. And therefore, that is what's going on. Other things that's going on with African Americans, particularly in the South, Georgia being hit specifically, is HIV. Huge population of
Right.
HIV
But
patients.
before we go into that, boy, you got this whole list of information, Dr. Lutz.
Because it's a lot.
She came with ammo. She's ready to go. Dr. Lucas, you were going to make a comment in that.
I was shaking my head yes, because I was going to bring up specifically what she just, I mean, I would be cheering out loud for what she just said, because when you asked me to be on this and you mentioned that you wanted to talk about things that people could do to reduce their own risk, and you didn't want to talk about, you know, some of the historical things that have beset minority communities in the United States, I don't think it's fair to have the conversation.
Oh, no, I definitely want to have that conversation.
Yeah, because, you know, I see that with my patients. When you have, you know, I take care of children that have congenital heart disease, and that the incidence of congenital heart disease is basically equal across the spectrum, because it's.
Okay, I was going to ask that. I was going to ask you that.
So when you come to my clinic, there's rich white people, there's poor white people, there's, you know, African Americans. We have lots of people from other countries, Hispanics, that don't speak English, and it's an interesting microcosm, because we're the only pediatric cardiology office in the upstate. We see people who are referred in from everywhere, and it's different. So, like you mentioned, Hispanic patients. You know, I speak muy poquito español. I'm working on it. But if one of my patients who's fluent English has a problem now, they pick up the phone, they can call my office, they talk to one of our nurses who speaks English, it's no big deal. And if they call at night, they talk to a hospital operator, they call and they talk to the pediatric cardiologist, it's easy. If somebody who only speaks Spanish calls, now there's an extra wrinkle, because if they happen to get lucky and get put on one of the hospital operators who speaks Spanish, then it's relatively easy. But if they speak to one of my partners, they need a translator to translate that. It just adds an extra step.
Absolutely.
It's a little bit harder. And then especially like Dr. Dr. Lutz said, there's a significant portion of our Hispanic population in particular that may not have the paperwork necessary to legally be in the country. So they're not going to call, and they're certainly not going to want to go to the ER at 2:00 in the morning because their baby that had heart surgery did something that they think may or may not be a problem. They're going to wait until they know there's a problem. And then oftentimes it's way, way, way later than we would have liked to get things worked. So those sort of things that exist in the biases that communities have about the way they've received care in the past, the way they've been treated in the past. And I mean, you mentioned Tuskegee. People, I know a lot of medical students, when we talk about that, think, well, that was a long time ago. And yeah, the 1920s was a long time ago. I know people who were alive in the 1920s or have, unfortunately, not very many of them now. But I mean, that's only 1 or 2 generations ago. So there's people in the South that their great grandparents either knew someone or had somebody in their family who was affected by that. So, I mean, that's a big deal. That'd be like asking me, well, ignore that World War II took place. And, you know, it's a similar kind of thing. So, you know, I mentioned that my grandfather was he fought in World War II, and after he got out of the military, my parents tried to get them to go back to Europe, and he always said the same thing. I've been there, I hated it. We're like, yeah, well, there wasn't, there was a war going on. There's not people shooting out there, but things that you grew up with or things that you experienced are going to taint your opinion about things forever.
Right.
So it's not really fair to look at, to go back to the African American community, it's not fair to look at that community now and say, well, just go get this immunization that they're going to come out with, or just go do this, or just go do that, because that history is there, that experience is there, and it was a real thing.
God, I'm starting to like this guy so much. I already love him to death, but I tell you, he's just so down to earth. What I hate was when people be deniers. I hate when people are like, hey, slavery has nothing to do with how you are today. Yes, it does.
Absolutely does.
I'll get a little bit more into that as well, but I was also going into about the lungs, the lung disease and things like that, and how it affects people as well. And is it a lung disease thing where people are born with it? Or is it where something they maybe obtain a little bit later? Now, I guess the born with question will go to Dr. Lucas, and then maybe later on, then we can come with Dr. Lutz.
Yeah, so it's not really clear. So I think I speak for most pediatric cardiologists and probably the pediatric pulmonologists. Mm-hmm. When I first heard that the novel coronavirus had sort of, for lack of a better term, sort of escaped from China, it was going to be a worldwide thing. My first thought was, oh my God, this is going to be devastating to our NICU graduates and to all of my patients with congenital heart disease, especially like single ventricle patients who are shunt dependent, stuff like that, because they have very abnormal lungs. Their oxygen saturations are not normal under normal circumstances. So if they get this respiratory virus, it's going to be devastating. I was kind of thinking of this, and Dr. Lutz will know what I'm referring to, kind of thinking of it was going to be like a super RSV. Every year, RSV decimates tons and tons and tons of patients, usually very younger, whereas us adults, you almost certainly have had RSV, but you just get it as a common cold and never think anything of it. Fortunately for the young patients, it looks like coronavirus is sort of the anti-RSV. There's at this point in time, there's actually 0 case reports of any children with congenital heart disease dying from coronavirus. It's not been devastating the NICU population. And there's a lot of potential explanations for that, but at least part of it seems to be that there's just something about the sort of younger immune system that's not as prone to having serious complications from this.
Okay, so Dr. Lutz, if you would take that on from that point, when you, as people get older, how are they, and I can only imagine a few of them, basically acquiring these lung diseases if they're not born?
So typically, first, primarily we're looking at asthma and COPD or emphysema, chronic bronchitis. And so COPD, chronic bronchitis, emphysema primarily have to do with exposures. And so that being primarily smoking. So whether or not you're a smoker, it can also do with exposures in the work environment, asbestos, those types of things, people that work in certain types of factories. And those are very, very specific cases. Asthma tends to be a childhood thing. It's something that you are predisposed to, tends to run in the family. It's kind of this triad of allergies, eczema, asthma, and so it's an atopic type of thing. And what we mean by that is kind of like an allergic thing, like your immune system is hyper responsive. And so I think that in part that makes it asthma kind of more of a risk factor in COVID. We think too, because part of the response that makes people really sick from COVID is a hyperimmune response as well. We don't really know. There's lots of theories going around as to why people get really sick with COVID. There's lots of things going on. There's a hyperimmune response. There's probably a cardiomyopathy, myositis. Dr. Lucas probably knows about that as well. Some people get asthma in adulthood. Like some people do these variants of asthma, but most people they get it in childhood, and they kind of we learn about that early on. We don't formally diagnose them until they're around 5 or 6. They have to be able to breathe in this fancy tube. But the COPD and the emphysema, that has to do with smoking. If you're a smoker, you're at high risk for that. And so what is
it with the smoking? First of all, I should form this question this way. You mentioned about pollution and smoking. Is there a different effect on the lungs that either one of those have, or is it just, does it do the same thing to the organs themselves, if that makes sense?
I would say two different things depending on the pollutant.
Okay.
So one is COPD is an obstructive process, and so it has to do with the amount of lung volume that you can breathe out. Okay, and certain other things, depending on what it is, asbestos or certain other kind of things, is a restrictive process. From the patient's perspective, you both have problems. You have problems breathing regardless.
Yeah.
So it's really from a physician perspective how we manage it and how it affects things. But they're different. It is
So
different.
the reason why I'm asking that, and to Dr. Lucas, is that we're talking about the disparities and where people live. Okay, so the reason why I wanted to kind of bring that out, because a person living in an area where perhaps there's a lot of factories, there's a lot of pollution, there's a lot of smoke. Would you see more people with lung disease and lung problems that might live in those areas as opposed to other areas? Who wants to take that on?
Yeah, I mean, I see her shaking her head yes, and I think that's the clear answer is yes. That's one of the issues with lower income neighborhoods is that they typically are the buildings in lower income neighborhoods are typically older. They're typically not as well maintained. They're more likely to have mold. They're more likely to have asbestos. They're more likely to be near major roadways where historically there'd be higher levels of lead in the soil back when we used to use gasoline.
Mm-hmm.
They're going to be exposed to more hydrocarbons from the rubber dust that comes off of tires, from diesel exhaust particulate, from automobile exhaust, and they're more likely to be near industrial areas because the zoning in those areas is not the same. If you try to build a factory in one of the nice neighborhoods just outside of Charlotte, there's going to be riots in the street.
They're going to vote against that.
They're going to vote against it. They're going to form a super PAC, and there's no chance it's going to happen. So they don't do that. They build it in a lower income neighborhood.
Oh, wait a minute. Hold on.
Voting.
Preach, as they would say. Now, say that one more time. I want to make sure.
Say it again, Dr. Lucas.
The audience is hearing this, because when we talk about these underlying conditions, there are reasons for this stuff. This is not that African Americans and minorities are sicker or just whatever. There are reasons for this, even if they are.
Mm-hmm.
Right. Yeah. There are definitely systemic cultural things. I mean, culture like the culture of the country, not the culture of the particular community. There's definitely differences in areas that give people advantages or disadvantages from a medical standpoint. I mean, that's very, very clear in all the literature. And if you talk to any public health official, I mean, that's blatantly clear. So even with congenital heart disease, I live in the upstate of South Carolina, where a couple generations ago there was lots of mills, and where there's lots of fabric mills, there's lots of dyes, and particularly in the early 1900s, late 1800s, that means that the water would be polluted. And if there was a study that was done at MUSC down in Charleston when I was there in the late 90s, early 2000s, where they looked at the incidence of congenital heart disease, and there was a theory that we haven't fully proven, but it still seems likely, that if you look at some of the poorer communities that live along the rivers and streams that were polluted, that were downstream from some of the factories, they have a higher incidence of congenital heart disease and congenital abnormalities overall, and that's because of pollutants. And if you look at the towns in West Virginia that are downstream from the coal ash, the ponds where they used to have coal ash, which is a known carcinogen, or even I'm from upstate New York originally, back where they used to have, form, I think it's called coal gas. There was some way that they could make coal into a gas to run streetlights, and it would have this byproduct left over. There's pits where they have that stuff sitting around, and people who live near that area and have well water have a dramatically higher incidence of all sorts of cancers. It's very clearly secondary to exposure to those things. So there's things that happen to you based on the zip code that you're born in that have potential effects for the rest of your life, no matter what happens to you after that.
Wow. Listen, okay, both of you guys have used the term about immunocompromised, right? What exactly does that mean?
Mm-hmm. Those are any factors that affects your immune system from how it should normally be functioning.
Okay.
Yeah. So that could be a lot of things. And so, kidney disease, HIV, a lot of things.
Right. Okay.
Lung disease. But there's a difference between immunocompromised and then hyperimmune, which was what I was referring to before with the asthma. Yeah.
Well, so, Daniel Hodges came on. He asked a question. I'm not sure about the question. Maybe you might get it. It says, have they heard of patients showing altitude sickness?
Yeah,
How is that relative? I'm not sure.
that's actually it's interesting. So I'm curious to see what Dr. Lutz has to add about that. So high altitude sickness is an area that was actually a particular interest of mine when I was in medical school and residency. And I have a couple of friends, Blake Grice being one of them, who Johnny might know. He runs Muay Thai school down in Anderson, South Carolina. And he goes out with some of his buddies in Wyoming and goes hiking at significant altitudes. When he gets up to 12, 14,000 feet, where altitude sickness is a potential issue. And we've had a lot of long talks about what he can do to try to prevent that from happening. And what Daniel's asking about is there's been some stuff in the literature recently that some of the patients with coronavirus are acting like they have something called HAIP, which is high altitude pulmonary edema. And because of that, people have started advocating for the use of a diuretic, Diamox, to try to prevent it from happening. But there's a couple of issues with that. One of them is Diamox is not really ideal for treating HAIP. It's for preventing HAIP. So like when Blake goes out, if he was going to fly from 300 feet altitude here in Anderson, South Carolina, to Wyoming, land at 9,000 feet, and then immediately hike 14,000 feet, which you shouldn't do, but that's a whole other story. It's not a bad idea to take Diamox ahead of time because it makes it less likely you'll develop altitude sickness. But if you get altitude sickness, Diamox is typically not the treatment of choice for that. It's treated differently. So, I've heard about that, but it's not really clear exactly what we're going to be able to do with that information. One of the things that has come up recently kind of related to this is there's been a thought, when coronavirus first started exploding around the country, you heard like Andrew Cuomo and some other governors talking about how they were going to need 30,000 ventilators all of a sudden. And now all of a sudden you're hearing that actually these ventilators that were bought, which wasn't anywhere near that much, aren't being used. And the reason for that is it seems like that permissive hypoxia is a reasonable treatment for coronavirus, meaning you can, if the person's sitting there and they're not in extremis, they're breathing comfortably, their PCO2 is okay, but their oxygen saturation is in the 70s, it may be safer to tolerate that than it is to ventilate them and try to drive their oxygenation up higher, because you can actually damage the lungs. The lungs are not designed to work under positive pressure ventilation.
Let me just say, both of you
100% agree.
are so articulate and have so much information, but I have an hour show that I was trying to do for just 1 hour. And look, and y'all said, well, I got to go at 1. Now, listen here. If you're going to give those long-winded answers, both of you guys, we're going to have to go over a little bit. Is that okay? Just a little?
Just a little bit.
Okay, just a little. Okay, all right. Because me, I'm long-winded. Did you want to add something to that, Dr. Lutz? About that?
No, I was just going to say I agree. I'm on the forums that physicians, and so and I just want to tell people that there are really, really smart doctors working on trying to figure this thing out. And I'm on the forums every day listening to this, and I agree with the same thing. I think that we're going to be moving away from using these ventilators as much as well, and it seems that it's probably that there is some component of this looking like that, and that the this positive pressure that's used in these ventilators is actually possibly doing more damage to the alveoli, which are the little parts of the lung that we use to exchange gases and oxygen.
Right.
And so again, there are reports of patients that are saturating at 60%, and normal is 94% or above, but they're saturating at 64%, texting on their iPhone in the bed. And so, and one of the ways that part of how they treat them is they put the patients on their belly instead of laying on their back. And so I just find this COVID fascinating. We're learning stuff every single day. I mean, I know that we don't want to say that about a virus, but I mean, it is interesting to see how it's acting, and we learn a lot about it every day. But yeah, I have heard of that. I've more to come on that. I'm not sure that there's anything like a formal thing that's come out about this. I don't think our system has really changed much in how they're managing it yet, but I think, like Dr. Lucas said, permissive, allowance of those little oxygen, as long as the patient can tolerate it. I mean, you don't want them to be huffing and puffing and working themselves to death at the same time.
Right.
But yeah, so it's fascinating.
Well, Dr. Lucas, he was going to go.
That's actually the reason why I've gotten contacted about patients with coronavirus. We talk about having people who look okay but have really low saturation. That's most of our patients with complex congenital heart disease. I mean, I have tons of patients with single ventricles who are literally running around at 2 years of age with sats in the 80s, and you would never know there was anything wrong with them until you look at their fingers and see they're clubbing or know they have a big median
Right.
So the congenital heart disease population and the doctors that take care of them have a lot of experience with that. So we've gotten involved tangentially with some of the adult ICU doctors who are a little bit more nervous about seeing that number that starts with a 6 or 7 on the saturation.
Well, I want to change gears here just for a second here. This is one of the big areas, that I've been preaching the gospel of fitness for years, right, to my family about what they eat and how they eat. One of the things that you might have seen when I started promoting that this show was going to come on, was a lady cooking the yams, right, and was dumping that big bag. I mean, it was amazing. I was like, I've looked at that probably 1,000 times just trying to figure out, okay, what are we thinking? Now, listen, those are going to be some pretty darn good yams. And the idea of what we call good as far as tasting. But I kind of want to dive in a little bit about, the people that are overweight and the things that we've eaten. But at the same time, this is where I was going to go back into our culture and our history and how we eat and what we eat. There was a time when, as not us, but our ancestors as slaves, right? They were thrown the worst part of the hog. They would throw them the guts and they would make chitlins out of them, okay? They would throw them the pig feet and they would pickle them and make something good out of those things, right? So there's a cultural part of this that's really, really important. But fast forward to maybe in the early 1900s or whatever, 1800s or whatever, late 1800s, that people were they were eating whatever they had available to them, right? If they had hogs, they ate the hogs, whatever was there, chicken, they would just eat it. And that was the way they were taught. My mama, she fed us what she could get, right? She had 8 kids and all. And so she would go and she would, cook up whatever she cooked, however she cooked it, whatever amount of salt it took to taste good, that's what she made. Right. And a lot of these restaurants and things like that, especially in certain parts and communities, they are just like this lady here with the yams. They're going for taste. They don't care about the health of this food. From a cultural perspective, Cordula, let's take you on first. What do you think about that and how we've been taught how to prepare foods that taste good as opposed to are good for us?
I think that's a hard thing. Not a hard thing, but I think that's the challenge as clinicians, right? And I think that's a community thing too that needs to be addressed, because you do want it to taste good and you still want to have your Thanksgiving and your meals. But what I try to tell my patients is not to say you can't have your yams and your macaroni and cheese on Thanksgiving, but you don't need to eat like that all the rest of the days of the year, right? You can still enjoy good foods and still have your traditional meals. But if you're a diabetic, or you have hypertension or coronary artery disease, or if you've had a stroke, honestly, you don't need to eat those types of things, and you need to look for substitutes and other ways to do it. The problem is that a lot of times patients don't know how to do it, right? And so, or they may not have the resources to learn how to do those things. That's all they know. And so it becomes our job as clinicians, if they're my patient, to help them to figure out ways to do that. So I do a lot of weight management in my office, and we also have the luxury of having a pharmacologist in our office that does extensive nutritional counseling. Nowadays, if you have access to the internet, honestly, you can look up ideas on substitutions on Pinterest. You can look things up, just Googling, like, how can I do a low sugar substitute for yams or something. But it comes down to the willingness of the patient and the openness of the patient to want to do those certain things. I have young patients that are very unwilling to make some of those changes, and they just rather me give them a pill, right? So I want to lose weight, just give me the pill that's going to do it. So it comes down to, on the individual level of things, the patient being open to make those changes, right? Because I can't force anybody. If I see somebody once a month, right, those other 29 days, or if I see them every 3 months, right? Those other 59 days or whatever, however many before I see them at their next appointment, they have to make those changes and be really willing to make those lifestyle changes. But you can do them though. There are healthy ways of cooking, right? And so in my future practice, I hope to be able to bring in somebody to be able to teach people how to cook healthily. It's possible. You can do it, but it does cost money though. I'm not going to lie, right? So, in the communities, I mean, I guess they have things like Aldi now, right? Which are generally cheaper, but it's expensive to eat well. I'm not saying you have to go to Whole Foods, but I like to shop and eat good food, but it's more expensive for me to do it. So I can't imagine not having the resources to be able to get fresh fruits and vegetables or to get the organic. I mean, there's the dirty dozen, the certain fruits and vegetables that you're not supposed to eat. Preferably unless it's organic, right? Because it can be bad for you because of pesticides that are grown in it and all that other kinds of stuff. So you have to factor in those things as well. I mean, there's a lot of things to consider when you're eating healthy. It's not necessarily easy.
Let me insert there, Dr. Lutz. First of all, let me just say this really fast, and I need to say this to this gentleman who came on, Gary Lee. Now, Mr. Gary Lee is someone, I want to just say to you, thank you, sir, because I know you're not on right now, and I've said this to you before, but I don't think you got it. Mr. Gary Lee was a big inspiration for me to actually start my Johnny Davis Live, right? He's been doing like his talk show and things like that for many, many years and all. And I was at an event in Atlanta, Georgia, and I saw him interviewing all these people, and people were lining up to talk with him. And it inspired me to say, you know what? I like to talk. Let me start my show. So, Mr. Gary Lee, thank you so much, sir. I appreciate you, and glad to know that you're doing better as well, sir. Okay, getting back, I want to talk about digress a little and go to a couple of the bad items and what they do to our bodies. Dr. Lucas, I know you want to get in on that, but I'm going to get you in on this a little bit differently about pork, in particular pork. I don't eat pork. I stopped eating pork. I got a long story, but I won't tell you why I stopped eating pork, but it involves a pet pig. That's a whole nother story. But I stopped eating pork when I was 12 years old, right? But a lot of us eat pork. And every time I ate it, it makes me a little dizzy, right? And I said, this can't be good for me. Tell me what about pork is so bad, Dr. Lucas, and why we probably should not eat as much as we do, if at all.
Well, I'm old enough to remember when they came out with a tagline for pork, the other white meat, and that was one of the big scams in nutritional healthcare in the past couple of decades. Because, I mean, pork, it's not a white meat. It's a red meat. And you should think of it just like any other red meat. And it's relatively high in cholesterol. I mean, you see that when you cook pork, especially if you're talking about, like using fat back to season something, or if you're eating bacon.
Don't talk about my mama. Don't you talk about my mama.
And in just like anything else, in moderation, it's probably fine. But if you're thinking, well, I'm going to eat red meat 5 days a week and white meat 1 day a week, and that 1 day a week you're eating white meat, it's pork chops, and you're eating your pork chops with collard greens that are really half fat back and just a little bit of greens, and then you're drinking a Coke with it, or a Diet Coke, or you're drinking whole milk or something else that's relatively high in fat, you're not doing yourself any favors. So I think the biggest issue with pork is the fact that it has somehow snuck into people's brain as being a good alternative to red meat.
But it tastes so good.
Oh, yeah, there's no doubt about it. I like pork. It's no coincidence I came up with a whole bunch of examples of pork.
Exactly. Okay, so for sake of time, I know, Dr. Lutz, you have some comments probably on that pork.
No, not about pork. My big thing is sugar. I'm very anti-sugar.
Okay, good. So let's move on to the next one, though. One of the things I was talking about earlier was about grease, right? And that the person was making some chicken and waffles, and the waffles were like in a gallon of grease. So grease plays a big role. Even my sisters, when they cook, I remember she was just glop, just put. I'm like, Oh my God! My
Crisco.
daughter this morning was making she actually had a piece of, I think it was some kind of bacon, turkey bacon or something. And then she had a turkey sausage, and she took the sausage and put it in the bacon grease. I'm like, you know what? You might want to dump off some. She's only 16, so she's learning how to cook. So you might want to dump off some of that grease, otherwise you're going to have a grease sandwich. Anyway, but the point of this, give us some of your thoughts about what is it about grease that's so bad? I probably fat has something to do with fat.
Saturated.
Why is it so bad for our bodies, Dr. Lutz?
It's the saturated. It's the nature of the fat. So not all fats are bad. It's the saturated fat, right? So I counsel my patients on the types of fats that they eat, right? So we don't like Dr. Lucas mentioned, the whole milks. Like we don't want those whole dairy products, right? And so the dairy fats, the meat, the fat from the meat, all those are saturated fats. Those fats are bad for your heart health. And so they increase your risk factors for heart disease, stroke, those types of things. But healthy fats, okay, so the omega-3s, those are all, they reduce inflammation, and those are good fats. They're good for the brain, particularly for children. They're good in brain development. And so those are things that are in like fatty fishes. So salmon, those types, sardines, those types of things have good healthy fats. Avocado is a healthy fat. Olive oil. And I'm sure as a pediatric cardiologist, the Mediterranean diet is something cardiologists encourage all the time as a preventive way of eating, or for people who for prevention of high blood pressure or management of high blood pressure. It also reduces the risk of Alzheimer's, cancer, stroke, those types of things. And so that's something that people can search for easily, but it includes a lot of healthy fats. The fats that I mentioned. So it's the type of fat that matters.
The type of fat.
Yeah.
Okay, Dr. Lucas, I know we're going to keep moving. Otherwise, I'm going to have you guys on here for 2 hours. But what do you want to say? What did you want to say about that?
I'm going to tee this up and hand it back to Dr. Lutz in just a second, because she started her talk with saying her big concern is sugar. And I think that's something that's unappreciated is saturated fats are definitely bad. But saturated fats, along with a lot of unrefined sugars, are probably significantly worse.
When you say unrefined, what does that mean?
I meant to say refined sugars.
Oh, refined. Okay.
So simple carbohydrates. So the picture of that woman dumping the 25-pound bag of Domino sugar. That's what I'm talking about. Is white sugar. So white sugar, other sweeteners, high fructose corn syrup, stuff like that, things that they use as ways to sort of hide simple sugars in other foods are probably a significant problem. It's probably much worse for you to eat that greased pork chop sandwich along with a big sweet tea that's 90% sugar.
Dr. Lucas, what you know about sweet tea?
We in the South.
And Kool-Aid, that Kool-Aid we make, right? And look, I mean, the half of the picture was full of sugar. It was sugar, and then I'm like, oh, wow, literally, they called it sugar Kool-Aid. It's crazy, yeah. So I mean, that kind of stuff. You're saying the compounding and the adding of that makes it that much
heart attack waiting to happen.
Absolutely, yeah.
Well, let's roll right into the next subject. I want to ask one of the underlying conditions of people with diabetes, right? Now, diabetes is something obviously that has a lot of different, factors. But eating the way we're eating with the sugars and the salts and things like that, how does that increase your chances of getting diabetes, Dr. Lutz?
So it's very multifactorial, but sugar, number one, is very inflammatory. So it produces a lot of inflammation in the body, which leads to a lot of different disease processes. So not just coronary artery disease, which in part is an inflammatory process. There's a lot of processes that lead to that. But so when you eat a lot of sugars and you're sedentary and you don't exercise and you gain weight, it makes the body resistant to insulin. And so normally when you eat, your body releases insulin and then it stores sugar, in the liver and as glycogen and all these normal processes happen. But when you start to do that more frequently, the body says, we do this all the time, and it doesn't recognize it anymore. It becomes resistant to it. And so then that is what leads to a pathologic or not normal process of diabetes. And so it's no longer responding to that insulin like it normally does before. And so it allows allows these blood sugar levels to be higher and higher. And so in the early process of that, if you're going to your doctor on a regular basis and we screen you for your diabetes, right? You're going to your regular physicals
So
and
you're
getting
saying
lab
go to the
work.
doctor and get checked early.
Right.
Right.
Because in the beginning, you're not going to sense any of this because there's no symptoms, right? When your blood sugars are in the 200s, maybe something like that, you don't get symptoms until it's like significantly higher and it's going on for a while. But in the beginning, you're not going to sense that. But later on, you know, you're with those blood sugars being high like that, it starts to become very toxic to the rest of your organs. Okay. And it starts to, speed up the formation of plaque in your arteries. It starts to affect your kidneys. It can affect your eyesight. It starts to affect your sexual organs. And so for men, that leads to erectile dysfunction, which for men who have erectile dysfunction, that's also a sign that you may have underlying coronary artery disease. So if you have that, you need to see a doctor and get a stress test. Make sure you don't have underlying heart disease. And so, you know, it affects the arteries in the brain. And so there's lots of, you know, but if we catch it early enough, the process is initially reversible. The problem is that so many people, they have it for so long and then we don't catch it. It gets to the point where you require insulin because you've pooped out your pancreas that has been, you know, producing this insulin for so long, it can't make it anymore. So then you become insulin dependent as an adult, and it starts to mimic type 1 diabetes.
So then now your immune system is weakened. So when a COVID comes along, you're more susceptible to that.
Right, because your kidneys aren't functioning too. Yeah.
Yeah, I want to ride right into what you mentioned about the kidneys and have Dr. Lucas take this one on. So, Dr. Lucas, what is it about that goes on with the kidneys that it weakens? I know it's kind of like a filtration system for your body, but give us a little bit more why it's important to take care of those kidneys and things that perhaps hurt the kidneys as well.
Yeah, so the kidneys have a lot of important jobs. So you mentioned filtering. So that's what everybody thinks of the kidneys doing. They filter the bloodstream. That's where your urine comes from. The kidneys also have some other important jobs. One of them is the kidneys and the glands by the kidneys actually regulate your blood pressure. So if you start getting significant kidney disease, that will oftentimes demonstrate or will be picked up because your blood pressure is extraordinarily high. So if you're doing things that are damaging your kidneys and you're not addressing it, so if you have significant diabetic nephropathy and it's not being addressed, it's going to lead to you having significant hypertension, which makes all of the other dangerous things that go along with diabetes more likely to happen. Stroke, heart disease. Actually, the high blood pressure itself can damage your kidneys, so it can become a bit of a self-fulfilling prophecy. So it's something that's very important to watch out for. Dr. Lutz mentioned in the talk that she just gave about the importance of seeing your primary doctor. And, you know, like I said, I'm a pediatric cardiologist, so we see patients up to 19 and then hand them off usually to Dr. Patel, who's our adult congenital specialist. And one of my canned speeches I start giving my patients when they're 17, 18 is you need to make sure that you stay in touch with your primary doctor as you get older. Because if you know you have a little bit of hypertension or you have prediabetes and your A1C is high and it's being followed by your primary doctor and treated, then you're way, way less likely to get those complications when you're older. But if you wait until you have erectile dysfunction or you start losing your sight or you can't feel your feet and you've got diabetic wounds, then it's too late. I tell people it's like if you have an oil tanker leaving the Middle East, if you turn that oil tanker a little bit as it leaves the Gulf in the Middle East, it can go to Maine or it can go to Florida, no problem. But if you wait until you're 50 yards off the coast of Bangor, Maine, and realize you want to be in Miami, you're not going to be able to fix that. So,
that's true if you know geography, but I wouldn't. But anyway, very, very good point, though. But I want to stay on that just for a second because one of the other things I noticed about the kidneys, you know, people take a lot of medication, right? And when we're taking, like you said, Dr. Lutz, about people just want a pill, but maybe give us an example of why we should not be taking so many pills and what it does to the kidneys, for example.
So one of the things I will say that people take that aren't necessarily a prescription that affect the kidneys that I see a lot of my patients take are BC powder and goody powders. Okay, so those are anti-inflammatories that affect the kidneys. And one of the biggest things that I see is that people take way more than what says the maximum is supposed to be on there. So that can be pretty dangerous, especially when you combine it with your prescription medications. And so this is why everybody needs to have a regular doctor that they see, a primary care doctor, internal medicine, family medicine, whatever it is that they see at least yearly, just to check in, to review your medications, to review your supplements, because you never know if something that you're taking is going to interact with something. And I've had patients that I've prescribed medications and they say, well, it didn't work. So I took twice. Two of them, right? And it was a medication, meloxicam, where it was 15 milligrams. That was the max. You can't just double it, right?
Right.
And so that could put you into acute kidney failure, right? And
Right.
so, even if a medication is over the counter, does not mean that it's benign, does not mean that it's harmless. And even these high protein diets, and it's not just medications. There's people are doing these low carb diets, or the Atkins diet or whatever. Low carb is a little different than Atkins,
Right.
or these high fat keto diet. That's different. But so these high protein diets, protein is also the kidney processes protein as well, and so that can be harmful to the
Okay.
kidney. So
So you're saying
protein powders can
right,
be
that's what I'm
harmful
at.
to
So
the
those
kidney, right?
protein powders that a lot of people are
Yes.
taking for whatever reason, right? Those are rough on your kidneys as well.
Yes,
Okay.
it can be for people that don't have normally functioning kidneys, which you don't know unless you see your doctor, right?
Right.
I mean,
Right.
so you don't know those things unless you're seeing a doctor regularly,
Right.
And I'm an advocate of people getting routine labs. They don't have to get them every year, but at least every couple years just
Sure.
to check and make sure, because you never know when things come up. But yeah, if you're taking high protein powders, you're doing a low carb diet, popping a couple BC powders, you just don't know. You're not drinking the proper amount of water.
Would
Things can.
ibuprofen also fit into that category?
Yes, ibuprofen, Aleve, meloxicam, diclofenac, Lodine,
Right.
BC powders, Goody powders. All those are
Very, very, very good.
NSAIDs.
So, Dr. Lucas, if let's say if a person is maybe taking more pain medication or ibuprofen than they should, drinking a lot of water, would that maybe help the process as far as flushing?
I mean, hydrating really well is a good idea pretty much all the time. Again, unless you have significant kidney disease, need to be water restricted, but it's not going to counteract the effect of taking too much medication. So I'm glad she brought up specifically ibuprofen. I know so many guys in the grappling community and in the kickboxing community that are taking 800 milligrams or more of ibuprofen 3-4 times a day for weeks or months at a time. And
we heard a lot, doctor. We heard a lot.
Yeah, they're following the carnivore diet, so they're eating all sorts of protein. They're taking all this ibuprofen. Yeah. You're just beating on your kidneys doing that. And a lot of the people who are doing that are young fighters who don't have a primary doctor, so they have no idea what their renal function is like. That's one of the potential, I think, things that might be a little bit better after this coronavirus thing is I see so many people who never gave a second thought to taking a bunch of ibuprofen posting now, don't take Advil because you'll die of the coronavirus. And
Right.
making people realize, just like you said, just because you can buy it over the counter doesn't mean it's a good idea to take, doesn't mean that it's perfectly safe. There's no such thing as a safe medication. There are safer medications, but if it has an effect on your body, and this goes for vitamins and herbs, if it has an effect on your body, some of those effects are good, some of those effects are bad.
Okay, I got about 3 minutes, guys, and I know you got to go, but I just want to kind of get through this real fast. Everybody good so far? Yep. Okay, good. Because I told you I was a little bit long-winded, and this COVID-19 thing gives me a little bit more time, so I can develop all of this stuff, over and over again. Okay, anyway. So sleeping, right? Somehow, I don't know how that is an underlying condition, or how does it maybe make you have an underlying condition? Could you give me some idea of how not getting enough sleep can maybe weaken your immune system? Dr. Lutz, would you like to take that one?
Yeah, sure. So a lot of the things that I always ask my patients, at least at their physicals, is how much sleep they're getting and whether or not they're managing their stress. And so sleep deprivation actually suppresses your immune system. And so I don't know whether the literature shows like a hard number. I usually tell my patients at least 6 to 7 hours of sleep. But it does suppress your immune system. The other thing, if there's an underlying sleep disorder, such as sleep apnea, that for sure would likely be a risk factor. I don't know specific to COVID specifically, but that does increase your risk factors for underlying heart issues though, like pulmonary
Okay, let me just say
hypertension.
this on my show right now. Let's enjoy the show while it's going on, because you guys are bringing out all these problems with me right now, like not getting enough sleep. So just in case I'm not here next year, guys, I really enjoy you guys on the show.
Mhm. That being said, I want to mention that because there was an article from the Arizona Integrative Medicine about some supplements that may be helpful. I don't want to tout this because I don't want people to go out and buy all this stuff. There is some evidence that that these may help, but melatonin has been touted as a possible immune booster for prevention, and so that may be why that made me think of it, but it may be why it helps because you may get more restorative sleep, vitamin D as well, and then of course people know about C and zinc, but. So that may be why, but yes, decreased sleep affects your immune system.
Right. An immune system is one of the questions I want to bring up. Somebody brought up about eating too much meat, right? And I guess that goes back to the kidney question or something, or maybe some other function. Does that somehow weaken your immune system by maybe eating too much meat? I know I kind of digressed a little, but I just wanted to ask that question.
I don't know about the evidence for that.
Yeah, so this is all that what I'm about to talk about is all bro science from the Joe Rogan podcast, because I'm not aware of there being any great studies. As Dr. Lutz can confirm, medicine in general, if you look hard enough, you can probably find a study that'll support your position. It's a matter of looking at the literature as a whole. But in nutrition in particular, it's the Wild West with studies because there's so many co-founding variables. It's very difficult. And that's why you see so many doctors advocating diets that are inherently contradict each other. But as far as I know, there's no evidence that excessive meat consumption or excessive protein consumption leads to any immune dysfunction. And there's some people who argue the opposite, that some folks that have immune problems, especially autoimmune diseases, do better on a meat-only diet because it saves them the pro-inflammatory aspects of simple sugars. So the carnivore diet in particular, there's a guy and his daughter that come on the Joe Rogan podcast on occasion that had significant lifestyle problems with autoimmune diseases, and they've apparently cured themselves by eating nothing but meat and salt. Now, how that's going to turn out long term, nobody knows. But to answer your specific question, I'm not aware of there being anything that supports a decrease in your immune function from meat consumption.
Okay, so when we talk about increasing your immune system, let's talk a little bit about two things. One, about exercise. Does exercise help increase your immune system? And if that is the case, why are so many gyms closed down? What wouldn't that be an essential business if it increases your immune system? I know a lot of gym owners probably want me to ask that question.
If I had $1 for every person who's messaged me on Facebook that owns a gym to ask that question, I probably would retire.
Right.
The issues are sort of, I think there's two issues at play. So first, yes, overall exercise done appropriately to improve your overall cardiovascular or aerobic fitness will improve your overall immune function. Having said that, immediate exercise, particularly to excess, can sometimes leave you a little bit immune depressed. So that's why, like I think we talked about before, that's why so many people who are cutting weight for fights will get a upper respiratory infection. That's one of the ways that I know I've overtrained. When I wake up in the morning and my heart rate's kind of high a couple days in a row, it's not unusual to then get sick not too long after that. Absolutely. The reason why they close gyms, though, is because of the close contact with people. It's for spread of the disease and the fact that there's so much shared equipment. If you go to a gym, like a weightlifting, Planet Fitness kind of gym, unless they're literally cleaning the equipment and cleaning the dumbbells every time they're put down, that's a potential source for spread, as is just the fact that there's a large number of people in a relatively enclosed space who are all breathing hard, they're coughing and stuff like that. So the close contact is an issue. If you happen to watch the president's talk yesterday, though, gyms are in phase 1 as long as they can practice appropriate social distancing for being reopened. And I think part of the reason for that is because people have been hearing you should do things to exercise, you should be healthy, so we're going to close all the parks and close all the gyms. With kind of
counterintuitive a little bit.
Follow, yeah.
Right. What are your thoughts on that, Dr. Lutz?
I agree 100% with what he said, and but it is a little bit hard. In the gym that I go to, she allows permissive kind of heat, so it's not cool. So I mean, it's an incubator. It would be an incubator for germs, and I mean, in some of the studies that I've seen, I mean, you cough. I mean, it's not just 6 feet. I mean, I think 6 feet is even a little bit. I think we're underestimating how far the virus can travel with a cough or a sneeze. So,
Okay.
it's not about exercising. It's about the social distancing and the spreading of the infection. But I do agree that there is a little bit of there can be a suppression of the immune system with exercising in excess, like that's short term, but for the long term, yes, you want to be, and this is a wake up call. I mean, for people, right? I don't think exercising now is going to help you, like going into a new exercise program now is going to help prevent you from getting this. I mean, you should have been fit. Ideally should be fit now, like all the time, right? I mean, so you want to get into a fitness regimen all the time in preparation for anything that can happen. I don't think this is the last epidemic that we're going to see.
Well, yeah, go ahead. So we're going to go ahead and ride right into this and maybe make this our final question, that about what things can we do? And we talked about exercise, yes, but you said exercise too, like losing weight could actually be detrimental to building the immune system. So give us some ideas, whether it's food or whatever it might be, to help build our immune system. Let's start with you, Dr. Lucas, on that one.
So, all the things that we've already talked about, and Dr. Lutz kind of just went through the last couple of questions. So making sure you get adequate rest, you're doing things, and I always have to say out loud whenever I talk about adequate rest, I'm the biggest hypocrite in the world with that. I'm that guy. I'm on call quite a bit. I don't get adequate rest most of the time. I get up at 4:30 in the mornings, regardless of what time I went to bed. I would definitely be better off with more sleep. So would everybody else. Eating a healthy diet, preferably a healthy, balanced diet. I'm not advocating to go out and jump on the most recent fad diet. You don't want to be on the grapefruit diet or the carnivore diet or whatever. You need to be eating a sustainable diet, something that you can maintain for the rest of your life, that's low in saturated fat and preferably as low as is reasonably achievable in refined sugar. So the sugar you're adding to things, high fructose corn syrup in products that are available, that kind of stuff, you need to try to minimize that. And getting regular exercise. You should be getting at least half an hour and preferably an hour of some sort of aerobic exercise every day. So something that's getting you out, breathing faster, getting your heart rate up. And I don't mean you don't have to necessarily go to the gym and do wind sprints on the treadmill.
Right.
Throw your dog on the leash, go for a walk around the block. Go out, ride your bike, go shoot some hoops, grab your jump rope, do burpees, look up body weight exercises on the internet and follow, right now, especially there's tons of trainers who have all sorts of exercise you can do at home. You can get a great workout without having to buy any equipment, without having to leave your house or your apartment. Mm-hmm. It's just a matter of getting in that habit, and doing those things will put you in better health, which will make you better able to survive and better able to be your best, regardless of what the health issue. I have yet to run across a health issue where the answer was eat worse, sleep less, be overweight, have hypertension.
Right.
The better shape you're in, the better your overall health is at baseline, the better you're going to survive whatever the insult is that you're worried about.
Awesome. Very good. Very good. Dr. Lutz, final word on that.
Yes. So in addition to those things, I would also say, if you are overweight, even a reduction of 5 to 10% of your weight has been shown to significantly improve or reduce your risk factors, for heart attack, stroke, those types of things. Stress management is a huge thing. I tell all my patients, managing your stress levels. A lot of my patients, they either hate their job or their family stresses them out. That is a major source of issues contributing to hypertension, contributing to diabetes. So getting those factors under control, whether it's finding a support system, doing yoga, doing meditation, going outside and putting your feet on the ground, whatever it is, but getting into a regular practice of stress management is so important. I've had patients that, once they've gotten that person out of the house or if they changed jobs or whatever, their blood pressure became under control after years of me being unable to manage it. So stress management is a huge component. out to see your primary care doctor, whoever that is, okay? Because we can't fix anything if we don't know what's wrong. And just because you feel good now doesn't mean you don't have something underlying that's going to be a problem that we can't fix in 5 to 10 years from now. So that's critical. In addition to the nutrition that he already said, healthy fats, healthy fats. So the olive oil, the avocado, the nuts and seeds, those are all heart healthy things that you can be eating. Definitely the avoidance of the sugar. People who have problems following a diet, I hate to use the word diet. I don't want to use the word diet. Use the word nutrition. So your nutrition. But if you are trying to lose weight, I'm a fan of intermittent fasting, so people can look that up about what that means. So if I'm ever trying to cut a little bit of weight, that's what I use. And then the last thing I would say is to please vote. So that has to do with stress. That has to do with your living conditions. That has to do with your health, right? So and honestly, it's not just the national issues. The local voting is so much, if not more important than the national issues, because it's directly affecting you where you live, your local community. So that's the last thing I have to say.
That's one of the things I was going to say too about voting, importance of voting. But Dr. Lucas, really quick, how can someone contact you on Facebook or any other type of social media?
So they can find me on Facebook. I think my profile is fairly close, but if we have any mutual friends, I'll probably accept your invitation. It's Jon Lucas. And then on like Twitter and Instagram, I'm pretty sure it's always some variant, and the same thing with some of the online forums. It's always some variant of SCMMAMD. Sometimes there's spaces, sometimes it's all crammed together, but some variant of that will be my username on it.
Right. Okay, well, guys, what about you, Dr. Lutz, really quick?
So it's Cordula Davis. So Cordula, and the last name is Davis on Facebook. I don't accept requests on Instagram, so it's more personal.
Right. So look, I know it's got people wondering now, you mean she's a Davis? Yeah, I told you I knew her.
That's a story for another time, ain't it?
A story for a whole other time. Thanks so much. You've been absolutely fantastic here today, and I appreciate you giving us the time and educating people more about how to live better and maybe how we can restore it or maybe prevent some of these underlying conditions today and maybe later on down the road. Thank you so much.
Thanks for having us. Nice to meet you, Dr. Lucas.
Nice to meet you too. Hope to see you in real life some point.
All right, that'd be cool.
All right, guys.
All right, bye.
Thank you. Bye-bye. All right, guys, there you have it. That was our edition today of Johnny Davis Live, talking about the underlying medical conditions that we have. We did focus a little bit on the African-American community and other quote-unquote minority communities, but you know what? It's everybody. It is about where you live. How do you take care of yourself? What are you eating? What are you drinking? All of those things that we talked about today. I hope that you will take some time and go back and check out our show. When you get more time, with all the valuable information on there that can really help you along the way. If not you, maybe help somebody else. Perhaps you have all the dots or everything in line. We always want to thank our sponsors at Blackout Fights at blackoutfights.com and Eastern Offset Printing for all they do for us. Okay, guys, that's it for me today. Hopefully we will be back on next Friday. Got a really fun show for you on next Friday as well. Guys, thanks so much for watching Johnny Davis Live. Please be sure to wash your hands. Continue to practice that social distancing. Guys, be safe, respect each other, and always forward march. This is Johnny Davis Live, and I'm checking out. Talk to you soon. Bye-bye.